So myself, Dr. Ramyashri. So tomorrow is the very important day for all of you because you will be giving your FMG exam. So first and foremost, I would like to tell you a few points before you go to your exam. Um, your target is 200, right? So 100 questions, even though they go wrong, it doesn't matter much for us. Tomorrow is the very important. So if you see some difficult questions, don't bother. Please don't pull yourself down when you see a difficult question. It doesn't matter. So if you see a difficult question, tell yourself this is the 100 which I am least bothered, right? Please don't commit any silly mistakes. How to avoid silly mistakes is read the question properly, understand the question, and read all four options and answer. Maintain the time, be positive. 100% you'll all do very well, so just be positive. So today's session, I thought we'll quickly go through all the important images pertaining to OBG. So all the important images pertaining to OBG will do. So do you want to solve some MCQs or do you want to do images? I'll be like, showing you the images, all maneuvers, all placentas, all important, like, a quick revision. So I was planning that way. So if you have any other thing also, you can let me know, like, because this is the last day where you want to, whatever help I can do for you all, so that's what I want to help you all. So my opinion is today we'll go through all the images at one glance, so that even if it comes in exam, it will be retained in your brain. So shall we do that way? Yes, Ash, Shahid, right. So we'll start with the images. First, I'm going to show you some USG based images and then we'll go through the maneuvers. So the first image which you're seeing is a ovarian cyst. Can you speak about this ovarian cyst? Most of the time, whenever you get any image, don't answer just on the basis of the image. My request to you is read the question and answer accordingly. Now, for this question, I'll give you some points. So this is a 25-year-old patient, old patient who has come to you with, who has undergone a TVS scan. On TVS scan, she is finding a cyst like this, which is of 6 centimeters. What should be your next step? What is your next step? Is my question. Options for this question is option A, follow-up, USG follow-up. Option B, cystectomy. Option C, oophorectomy. I hope there's no problem and class is going on. Right. Option C, oophorectomy. So answer from these three options, no? So what is this image? So she underwent a pelvic scan and this was the image which you saw. And how do you treat this case? Okay, one more thing I'll tell you. Manu, you have answered it correct or you have answered it wrong. You should not at all consider. If you are answering many questions wrong now, no, you take it as positive. Ki, okay, I've learned so many before going to exam karke. Okay, that should be your attitude. But I want all of you to attempt. Okay, let's read about this image now. So this is an ovarian cyst. How do I tell this is an ovarian cyst, not a fallopian tube abnormality? Ovarian cyst is usually round to oval. Ovary ka kuch bhi related will be round to oval. So if you observe here, it is round to oval, right? And it will be thin walled. Can you see the wall is so thin? The wall is so thin. How is it inside? Is it homogeneous or heterogeneous? Is it homogeneous or heterogeneous? It's completely homogeneous. Homogeneous, hypoechoic. Homogeneous, hypoechoic, right? By one look, what do you say? Is it a benign ovarian cyst or is it a malignant ovarian cyst? Is it benign or malignant? The next question arises, is it benign or malignant? So as it is homogeneous and it is hypoechoic, it is fluid filled basically, and it is a simple ovarian cyst. Why? Because in complex ovarian cyst you will have thick septations, it will be multiloculated, it will have heterogeneous patterns, some solid areas inside, but you don't see anything here. It is like a fluid filled balloon ovarian cyst. It is a simple cyst. To be frank, this simple cyst, which is query, looks like a follicular cyst. What is the most common ovarian cyst in a female? The most common ovarian cyst is follicular cyst only. We tend to get follicular cyst. And what happens to this follicular cyst? Do they regress by themselves or do we require to treat them? Normally, follicular cysts regress by themselves. You don't require to give any treatment. Another way how we could have solved this was, even if I didn't have this image, no, this image is supporting, but what are the points which were supporting and which you wanted, which by how you had to answer this was, whenever you have an ovarian cyst, whenever you have an ovarian cyst, you have one of two tables which are very, very, very important. This might come to you in exam also. So that is, in a reproductive or premenopausal woman, in a reproductive or premenopausal woman, if they come to you with ovarian cyst, if the size of the cyst is less than 5 centimeters, just wait and watch. Don't bother about it. Most of them resolve by themselves. Okay? Wait and watch. You can do a USG follow-up also. If it is between 5 to 7 centimeters, if it is a simple cyst, wait and watch and USG follow-up. If it is more than 7 centimeters, or if it is 7 centimeters, between 5 to 7, and a complex cyst means they should have some solid areas, multiloculated, thick septations, then we call it as a complex cyst, right? So if you have a complex cyst or a cyst more than 7 centimeters, that is when you have to go for surgical management. Again, surgical management doesn't mean oophorectomy. You have to understand what is it and treat it accordingly. So probably cystectomy, or if it is a tumor, you think, then staging laparotomy and oophorectomy. Depends on what case it is, right? So my question, which I gave you, was a simple cyst of 6 centimeters. As my question was simple cyst of 6 centimeters, your answer will come in USG follow-up. USG follow-up. Understood? So this is the first table. This is the first table. Second table, which you should be well aware and well, again, which can be asked as an MCQ, is if you have a postmenopausal woman with ovarian cyst. Mano, the same question, same image, and I would have given 54 years old, came with you to 6 centimeters ovarian cyst. What is your first step? Then what will be your answer? Postmenopausal with ovarian cyst. What is your first step? If you have a postmenopausal woman with the ovarian cyst, irrespective of the size of the cyst, you are supposed to do CA 125. You are supposed to do CA 125. If CA 125 is less than 35 international units per liter, weight, and then you have to see the size. Size is less than 7 centimeters, USG follow-up. If size is more than 7 centimeters, then remove, surgical removal. If CA 125 is more than 35 international units per liter, irrespective of the size, surgery. Guys, this is a very, very, very potential point which can be asked. Irrespective of size, surgery. Okay. So along with the image, the history also matters. Along with the image, the history also matters. So this was regarding the first image of the ovarian cyst, which we have learned. Now let's see the next image. Let's see the next image. Now, unlike the previous image, what is the shape of this? Unlike the previous image, how does this look like? This looks like some elongated sausage shaped. So elongated, what is the structure which is a genital structure and which is elongated? That's the fallopian tube, right? So this is a distended fallopian tube. This is a distended fallopian tube, which is giving you a picture of hydrosalpinx. Just try to register the images in your brain, okay? Because last time you got 80 images. What probably, like in this class, I'll try to strike at least 50%. Today we revise, tomorrow it should come. Like that it should be, okay? So just concentrate. The next 1 hour, I want you to give maximum concentration in this class, and probably we will have a good strike rate, okay? So this is a hydrosalpinx. It is a distended fallopian tube. Distended fallopian tube. So it will look like a sausage shaped. And if you observe, there are septations. But what is the description of these septations is, it has septations, but these septations are incomplete. Unlike your ovarian cyst. If ovarian cyst, you'll have complete septations. But unlike your ovarian cyst, this will have incomplete septations. Unlike the ovarian cyst, this will have incomplete septations. And incomplete septations, so this is called as cobweb appearance or cogwheel appearance. Cogwheel appearance. I think last exam you got a HSG image of bilateral hydrosalpinx. Last to last exam somewhere you got a HSG image of hydrosalpinx. I'm showing you USG image of hydrosalpinx here. Okay. Sausage shaped cogwheel appearance. Right. This is a specimen of hydrosalpinx. Last exam, they gave you the ovarian cyst ka specimen. On table, patient lying and ovarian cyst ka specimen, right? How do you have to identify also? I'll tell you. They give fibroid is one common specimen they can give you. Adenomyosis is another common specimen they can give you. This is a hydrosalpinx ka specimen. How do you have to identify is, see, uterus. This is a uterus. This whitish which will be there, no, there will be always ovaries. Above the uterus, above the ovaries, you will have the fallopian tube. So these are the fallopian tube. So this side fallopian tube, I can see this side fallopian tube is enlarged and it is retort shaped. So retort shaped fallopian tube is again a hydrosalpinx. Retort shaped is hydrosalpinx. Okay. This is a picture of complex ovarian cyst. Now, why do I say this is a complex ovarian cyst? It is a malignant ovarian tumor. Why? See, irregular. It is not proper oval. It is irregular. Irregular. This is full solid area. Then cyst, multiloculated, solid area, right? So this is a malignant ovarian tumor. See here also irregular. Solid area, thick septum, multiple cysts. This is a surface capillary excrescences. This is a surface capillary excrescences. This is the increased vascularity which you have, strong blood flow you have. This is a complex ovarian cyst. This is a complex ovarian cyst. Okay. Probably an ovarian malignancy. Probably an ovarian malignancy. What is this one? This you will identify. Many of you will answer this one. What is this one? So you have the hair, sebaceous material, protuberance. Which ovarian cyst is there? Is this? Which ovarian cyst has hair, sebaceous material, and Rokitansky protuberance? Excellent. This is nothing but a teratoma. That is dermoid. That too you have to tell mature teratoma. So this is dermoid cyst or mature teratoma. Dermoid cyst or the mature teratoma has the Rokitansky protuberance, hair, sebaceous material, thin cyst wall. Dermoid cyst has many single liners, guys. It is the most common germ cell ovarian tumor. It is the most common germ cell ovarian tumor in young girls. Most common benign germ cell ovarian tumor. It is the most common benign germ cell ovarian tumor. Okay. It is the most common ovarian tumor in pregnancy. It's the most common ovarian tumor in pregnancy. It is the most common ovarian tumor to undergo torsion. Treatment of dermoid cyst is cystectomy. Means you just have to remove this cyst. Treatment of dermoid cyst is cystectomy. Okay. So those are some of the important single liners pertaining to the dermoid cyst. Dermoid cyst only treatment is just remove the cyst. You don't require to do anything further. Another important is fibroid. So fibroid, so this is a uterus. Can you see this is the myometrium? This is the endometrium. This is the myometrium and this is the endometrium. In the myometrium, posterior wall, if you're observing, you're seeing a mass. Again, how do you describe fibroid? Fibroid will be homogeneous hypoechoic. Fibroid is homogeneous hypoechoic. Fibroid is homogeneous hypoechoic. This is a posterior wall fibroid. The main description is it is a homogeneous and hypoechoic mass. So basically you will see them arising from the uterine cavity. Fibroid, even the cut section is important. So fibroid usually is covered by a pseudocapsule and it will give you a bossylated appearance. It will give you a bossylated appearance. This is the ovary, this is the cervix, this is a bossylated appearance and cut section will have whorled appearance with a pseudocapsule. See, there are fundal fibroid and again there is a submucosal fibroid also projecting into the cavity. So this is a fibroid. So last time they gave us ovarian cyst. So probably this time they can ask you fibroid also, right? Another important image is adenomyosis. Let's see the adenomyosis also. Can you tell me what is this? It's a posterior wall hyperplasia with heterogeneous echoic multiple cysts. Can you see there are multiple cysts inside the myometrium? The multiple cysts. So indeed, this is called as salt and pepper appearance. These multiple cysts in the myometrium, this is called as salt and pepper appearance, or we also call it as Venetian blind appearance. Venetian blind appearance. Okay. And I'll show you. This is the once this was asked as an MCQ also, this picture. So this is the posterior wall hyperplasia with multiple ovarian cysts. Sorry, multiple subendometrial cysts. Okay, this again in adenomyosis, uterus will be uniformly enlarged and it will be tender. Tender uterus in adenomyosis is called as Halban's sign. Adenomyosis is presence of functioning endometrium into the myometrium. Presence of functioning endometrium into the myometrium, right? So unlike your fibroid, usually fibroid is the differential diagnosis for adenomyosis. Unlike the fibroid, which is bossylated appearance and having a irregular surface, this is going to be regular enlargement of the uterus. This is going to be regular enlargement of the uterus. And on USG, the differences between the fibroid and adenomyosis is fibroid is well circumscribed, but you saw adenomyosis also spot. It's scattered all through the posterior wall. So it is poorly circumscribed. This is poorly circumscribed. You have poor defined periphery. It has well defined periphery. You have subendometrial myometrial cysts. Adenomyosis is a heterogeneous echo pattern. This is mainly hypoechoic. Contour abnormality is there. No contour abnormality. It has scattered vascularity. This mainly has peripheral vascularity. So these are some of the differences which you have between the fibroid and adenomyosis. Yes, Shahid, you're correct. Most of the adenomyosis go up to 12 to 14 weeks, but fibroid can grow to any size. Okay. I'll ask you a few more questions here. What is the investigation of choice for adenomyosis? What is the investigation of choice for adenomyosis? What is the investigation of choice and what is the gold standard? Mainly investigation of choice is something which you have to answer. What is the investigation of choice for adenomyosis? The investigation of choice for adenomyosis is MRI. First line, excellent, Shahid Afreed. So very good. The investigation of choice for adenomyosis is MRI. On MRI, these are not the things which we consider. We consider something called as junctional zone thickness. And if the junctional zone thickness is more than 12 mm, it is more than 12 mm, then we call it as, if the junctional zone thickness is more than 12 mm, we call it as adenomyosis. So investigation of choice is MRI, whereas first line is TVS. First line is TVS, but investigation of choice is MRI, guys. That's also one more very important point. On MRI, you will see junctional zone thickness. That means between the endometrium and myometrium. The thickness is more than 12 mm, we call it as adenomyosis. Okay. And one more MCQ which came in the recent time might be repeated is, if you have an asymptomatic fibroid of 14 weeks, what is your management which you would like to do? If you have a asymptomatic fibroid of 14 weeks, what is the management which you would like to do? Asymptomatic fibroid of 14 weeks, what is the treatment which you would like to do? You can answer that. So now we'll see some OBS also. I'll show you some maneuvers. Just before going exam, the maneuver images are very important for us, right? So we'll see maneuvers. Excellent, Anjana. So whatever might be the size of the fibroid, if the fibroid is not symptomatic, you can just wait and watch or leave her alone, right? Excellent. Okay. So quickly, can we speak and go through the images of obstetrics now? So this one, which you're seeing, is the, oh, sorry. So this is the part of the decidua which is present below the blastocyst. This is called as decidua basalis. The part of the decidua which is covering the blastocyst is called as decidua capsularis. The part of the decidua which is covering the entire uterine cavity is the decidua parietalis. So we mainly have three things here: decidua basalis, decidua capsularis, and decidua parietalis. So decidua basalis is present below the blastocyst. Covering the blastocyst is decidua capsularis. Covering the entire uterine cavity is decidua parietalis, right? And if this same image is present in the USG, what is that appearance called as? On USG, decidua capsularis and decidua parietalis form two rings around the gestational sac, which we call it as double decidual sign. Guys, actually, I don't think so. I have the picture in the coming up also, but double decidual sign I was asked as an image based to you. So I'll just show you in the last after all these images. Just remind me, okay? Now, slowly as and when the baby is growing, the decidua basalis remains the same. But please observe the image. Yahan pe decidua capsularis and parietalis. Two things were there. Covering the baby and covering the uterine cavity. Two things were there. As and when the baby is growing, this capsularis and parietalis will fuse with each other. This capsularis and parietalis will fuse with each other and it will form decidua. It will form decidua vera. It will form decidua vera. So what will it form? It will form decidua vera. Okay. Decidua vera is formed at how many weeks is also one MCQ. It is formed around 14 to 16 weeks. But if I have to answer a single line, I have to go with 16 weeks. If I have to answer with single line, single word, it will be 16 weeks. Okay. Right. And what is this one? The part of chorion, which is present towards the decidua is called, which is projecting into the decidua and helping you in the formation of the placenta. What is that called as? That is called as chorion frondosum. That is called as chorion frondosum. And the part of the chorion which is present opposite or which is lying below the decidua vera is called as chorion levae. Chorion levae. Right. So you have chorion frondosum and chorion levae also. And what is the one which prevents the chorion frondosum to invade into the myometrium is Nitabux fibrinoid layer. And whenever there is absence of Nitabux fibrinoid layer, it will lead to morbidly adherent placenta, that is accreta, increta, and percreta. Right. Now some more abnormal placentas. So this is a circumvallate placenta, which has a central depression. So can you see there is a central depression? And it has double fold of amnion and chorion. Double fold of amnion and chorion. Right. Next one. And these both circumvallate and circummarginate are called as extrachorial placentation. They're called as extrachorial placentation. In both of them, chorionic plate is smaller than decidual plate. Chorionic plate is smaller than decidual plate. So they have the risk of antepartum hemorrhage and preterm labor. This is circummarginate. Circummarginate mein you will have single fold of amnion and chorion. How do you remember between valate and marginate? Is marginate mein you will have peripheral margin. The single fold is only peripherally as a margin. Circumvallate mein you will have a central depression, right? So this is a succinturate lobe. So where you see one cotyledon separate from the entire placenta. So when you have one cotyledon separate from the entire placenta, you call it a succinturate lobe. What might be the abnormalities which you can face with the succinturate lobe? You can have the risk of secondary PPH, sepsis, and subinvolution. Okay. Velamentous placenta. When do we call velamentous placenta? When cord is attached to the membranes, you call it as velamentous placenta. When cord is attached to the membranes, you call it as velamentous placenta. What is the risk associated with velamentous placenta? The risk associated with velamentous placenta is it can lead to fetal hemorrhage. This is the placentation which can lead to fetal hemorrhage. The rest all placentation lead to maternal hemorrhage. But this is a placentation which can lead to fetal hemorrhage, and it is also associated with something called as vasa previa. Vasa previa. So what is vasa previa? Vasa previa is seen with placentations of velamentous placenta. Is seen with velamentous placenta. It is seen with placenta bilobata. And it is seen with succinturate lobe. Basic concept here is, what is placenta bilobata? When two equal halves of placentas are separated by membranes and vessels, you call it as placenta bilobata. What is succinturate lobe? Succinturate lobe is one placenta and one cotyledon connected by vessels and membranes. Okay. And when this vessels with membranes is present below the presenting part and above the internal os, we call it as vasa previa. It can be seen on a TVS with Doppler, and treatment for this is cesarean section, elective cesarean section. You should never allow them to go into labor. You might get a clinical question that a patient was come to you and suddenly membranes ruptured, baby heart rate dropped down to 50. What is your diagnosis? Vasa previa. Sudden, after membranes got ruptured, sudden bradycardia, you should think of you should think of vasa previa. It can be cord prolapse also. It can be cord prolapse also, right? Can you tell me what is this procedure? Do you want to guess what is this procedure? Yes, I want you people to answer, what is this procedure? I'll speak a few words about this animal. So this is, if you're observing, there is an ultrasound. On ultrasound, there's a needle going to the placenta and they're taking the tissue. Very good. This is chorionic villus sampling. This is chorionic villus sampling, right? Next image. So the one which you saw just now was chorionic villus sampling. The next image which you're seeing here is amniocentesis. Amniocentesis. So again, ultrasound guided, they're sending the needle and they're tapping the amniotic fluid for checking the karyotyping. So this is called as amniocentesis. Okay. This one, where the needle is going towards the cord and from there they're taking the blood. This is called as cordocentesis. This is called as chordosynthesis. So basically you have three things here, guys. You basically have three things for karyotyping. One is chorionic villus sampling, CVS. One is amniocentesis, one is chordosynthesis. Now, give me a 2 minutes for revising you through the aneuploidies. Give me 2 minutes for revising you through the aneuploidies. Last time, not only last time, guys, I seriously tell you from past 3 years, there is one question on aneuploidy. They ask you what is trisomy 21, or they're giving you karyotypy picture of trisomy 21, or they ask you what is Edward. So I think that question should be like, grace mark, you should get it. So we basically know mainly three trisomies, that is trisomy 21, which is Downs. Trisomy 18, which is Edward. And trisomy 13, which is Patau. Right, so you mainly have three things here, that is trisomy 21, trisomy 18, trisomy 13. How do you screen for this? So you have screening methods and confirmatory methods. So screening methods may, again, you have first trimester methods and second trimester methods. First trimester, they are done between 11 to 14 plus 6 weeks. 11 to 13 plus 6 weeks. First trimester mein you have double marker. Double marker is beta HCG plus PAP A, not Papa, PAP A, right? But detection rate is very less. So you have next one, that is combined screening test. Combined screening test is beta HCG plus PAP A plus third one is NT scan plus NT scan. That is knuckle translucency scan, where you check the nuchal translucent area. How much is the translucent area which is present karke, right? So NT scan is again done between 11 to 13 plus 6 weeks itself. But here it is done when crown rump length is between 45 to 84 mm. And the cutoff NT scan, when do we call NT scan normal? When NT scan normal is, it should be less than 3 mm. If it is more than or equal to 3 mm, you should, the first cause which might have increased NT is Downs. Second most common which can cause increased NT is Turner's. And the detection rate for combined screening test is 82 to 84%. Fair enough, right? Next, you have the second trimester screening methods. Second trimester screening methods are between 15 to 20 weeks. Okay. And in this 15 to 20 weeks, you have triple marker. Again, triple marker, Gaya Jamana, it is like an old one, but yes, better we read it, because probably if they ask in exam, we should get the question marker. So triple marker, it is beta HCG plus PAP A plus, sorry, there is no PAP A, beta HCG plus unconjugated estriol plus AFP. Not so good method. Detection rate is only 60%. So the second trimester best screening method is quadruple test. Quadruple test. Quadruple marker mein you have beta HCG plus inhibin A plus unconjugated estriol plus alpha fetoprotein. Quadruple marker mein you have beta HCG plus inhibin A plus unconjugated estriol plus alpha fetoprotein, right? And in this quadruple marker, H stands for high, I stands for increase. So for Downs, your H for high will increase, your I for increase also will increase. Whereas unconjugated estriol and AFP both will decrease. Okay. So these are the first and second trimester screening. If you're doing combined, both for detection rate of quadruple marker is 80 to 82%. Matlab almost similar to your combined screening method, right? If you do both these together, that is first trimester as well as second trimester ke both together, first and second trimester together, you call it as integrated screening tests. You have integrated screening tests which can be intermittent or sequential, but you don't require to go into the depth of integrated. Integrated detection rate is 95%. Now please remember, if your first or second trimester screening and screening methods are getting abnormal, you have a next step of screening test that is called as cell-free fetal DNA or NIPT. Cell-free fetal DNA or NIPT is, you take the maternal blood to detect cell-free fetal DNAs. To detect cell-free fetal DNAs, the detection rate of this is almost 98 to 99%, but it's still a screening method. If you have an abnormal cell-free fetal DNA, you go for confirmatory methods. Confirmatory methods are, and one more thing, cell-free fetal DNA can be used from 10 weeks till term. Anytime you can use. Cell-free fetal DNA is contraindicated in twins. Cell-free fetal DNA is contraindicated in twins. Confirmatory method is chorionic villus sampling, amniocentesis, and cordocentesis, which we saw all the pictures, right? Chorionic villus sampling is done between 10 to 13 weeks. Amniocentesis is done between 15 to 20 weeks. Cordocentesis is done between 18 to 20 weeks. Chorionic villus sampling is done between 10 to 13 weeks. Amniocentesis is done between 15 to 20 weeks. Cordocentesis is done between 18 to 20 weeks. Okay, and chorionic villus sampling, you take the trophoblast for karyotype. Amniocentesis, you are taking amniocytes, that is fetal skin epithelial cells for karyotype. Here you are taking the fetal blood for karyotype. Here, quick results. Within 24 hours, you will have the results, but abortion rate is 2 to 3%. Abortion rate is 2 to 3%. Amniocentesis, preliminary results within 24 hours, but culture results 1 week. Culture results 1 week. Amniocentesis, it is 0.5 to 1%. In this 0.5% itself, not 0.5 to 1. 0.5% is the abortion rate. So what do I mean by this? Amniocentesis is safest among all. Chorionic villus sampling it is again same preliminary results within 24 hours, culture result in 1 week, but this has the risk of what do you say? Oromandibular defects and limb reduction defects. Abortion rate is around 1 to 2%. That's about the aneuploidy screening in a short manner. Now let's go back to our images and see further images. Leopold maneuvers are again one more important which can be asked. So the first 3 maneuvers are by seeing the patient's face, whereas the last maneuver is by seeing the patient's feet. So this is the Leopold first maneuver, which you call it as a, what do you call this maneuver as? It's called as fundal grip. It's called as fundal grip. Leopold maneuver is called as fundal grip. So what do we do in this fundal grip? So INI CET they gave this as a question, guys, and I feel it is a potential question they can give you also as an image. Okay. So this is a fundal grip. So here with the palmar aspect, you're trying to palpate the fundus. On the fundus, when you're trying to palpate the fundus, if you're able to feel soft, broad, irregular structure. Iska matlab you are feeling buttocks. This fundal grip helps me to find out what is present opposite. See, if I know what is present above, obviously uska opposite is present down. So it is helping me to tell you the presentation. So if fundus or buttocks are felt up, so what is the presentation? It will be cephalic presentation. It will be cephalic presentation, right? If you feel there is a hard, curved and globular, if you feel there is a hard, curved and globular structure, then it is the head, which is ballotable also. It is ballotable also. So whatever is present above, ulta will be present down. So it is telling us presentation. Manu, if you don't feel anything in the fundus, it means you are dealing with a transverse lie, right? Second grip, this is a Leopold first maneuver, or you also call it as fundal grip. The second Leopold maneuver, the second Leopold maneuver is also called as lateral grip. Is also called as lateral grip. The second Leopold maneuver is also called as lateral grip. If you're feeling, or it's also called as umbilical grip, guys. Lateral grip or umbilical grip. Okay. If you feel there is a smooth curvilinear resistance, smooth curvilinear resistance, then it is the fetal back. If you feel multiple knob-like structures, then it is limbs. Whichever side you feel the back, whichever you see side you feel the back, that side you will have the fetal heart rate. That is the side where you will have the fetal heart rate. Okay, so that's the lateral grip or the umbilical grip. Next, let's go to the next one. That is third grip. Third Leopold maneuver is also called as Pollick's grip. Pollick's grip. It's called Pollick's grip. So Pollick's grip may thumb on one side, four fingers on another side. Again, it is to confirm the presentation. To confirm the presentation, and it also helps you to find out whether the presenting part is engaged or not engaged. So it confirms the presentation and it also tells you whether the presenting part is engaged or not engaged. If if the head is full ballotable, it means presenting part is not engaged, right? Fourth pelvic grip, fourth Leopold maneuver is called as pelvic grip. Pelvic grip. Fourth Leopold maneuver is called as pelvic grip. Okay. Guys, don't take this light. I 100% tell you, you have to know this because it can be potentially asked in your exam. Okay. Everything what I'm showing you now can be potentially asked because you know you always keep asking me what is the last minute I have to revise, last minute I have to revise. Those are the last minute points, the golden points I'm telling you. Okay, so pelvic grip may you try to palpate. Okay, while you're trying to palpate, if your both hands are converging below the presenting part, it means the presenting part is not engaged. But if your hands are diverging when you're palpating, it means presenting part is engaged. So it helps you to tell the whether the presenting part is engaged or not. Extra point. It also tells you the degree of the flexion of fetal head based on sinciput and occiput. Now, okay, it is not the time for extra point. At least remember this is picture is pelvic grip. Now to full up to the point, right? So first one is fundal grip, second one umbilical or lateral grip, third is Pollick's grip, fourth is pelvic grip. How to remember which is the fourth one? All the first three are by seeing the patient's face. Only the fourth or the pelvic is by seeing the patient's feet. Okay, that is one more thing I want you to remember. Okay. Next, partogram. Partogram starts at how many centimeters dilatation? Partogram starts at 4 centimeters dilatation. Partogram starts at 4 centimeters dilatation. So from 4 to 10, the rate of dilatation is 1 centimeter per hour, which we take. So that is this is called as alert line. And 4 hours apart from the alert line, you have the action line. 4 hours apart, you have the action line. 4 hours apart, you have the action line. So between alert line and action line, each small box on x-axis is 30 minutes and 2 boxes make 1 hour. Okay. Now, normal partogram. Normal partogram should be always before alert line. So normal partogram should be left of alert line. If alert line crosses, if your partogram crosses the alert line, then refer to higher center or get alerted. If it crosses the action line, you have to take intervention as per the situation. Okay. Partogram still is starting, modified partogram is still starting at 4 centimeters. But according to Williams, latent phase is up to 0 to 6 centimeters or 5 centimeters, whatever you want, right? And active phase starts from 6 to 10. Active phase starts from 6 to 10. Okay. So that is according to the Williams. But partogram is still starting from 4 only, no? What is this maneuver, guys? What is this maneuver? Where you are, where the perineum, where you are giving the perineal support and flexing the fetal head to deliver the head controlled. So this is the second stage, and second stage delivery is called as Ridgen's maneuver. Ridgen's maneuver. Okay. So this is called as Ridgen's maneuver. Ridgen's maneuver. It's how we deliver the second stage. So this picture, the next picture which you're seeing, one hand on the abdomen and with another hand you're holding the cord and trying to pulling out. This is called as Brandt-Andrew method or control cord traction. So this is for the active management of third stage of labor. So this is called as Brandt-Andrew method or control cord traction. Okay. Now, some more important points is one, you should know about episiotomy. Second, you should know about the active management of third stage of labor. So coming to the episiotomy. So episiotomy is a planned liberal incision on the perineum to make the perineal space increase for the easy delivery of the baby, right? So episiotomy is, what are the muscles which we cut in the episiotomy? The muscles which we cut in the episiotomy are bulbospongiosis, superficial transverse perineum and deep transverse perineum. Bulbospongiosis, superficial transverse perineum and deep transverse perineum. Next, some part of levator muscle is also cut. Pudendal nerves and branches. Pudendal nerves and branches. So those are the muscles which are cut. And what are the structures cut? The next thing is that the episiotomy is, mediolateral episiotomy is preferred. So mediolateral episiotomy makes an angle of 60 degrees from the midline on the stretched perineum. It makes an angle of 60 degrees from midline on stretched perineum. Whereas it makes an angle of 45 degrees from the midline on after delivery. So 45 degrees from midline post delivery. So these are some of the points which you should be knowing. So how much angle it makes from the from the midline also is many times asked. So from the midline it makes 60 degrees on the stretched perineum and 45 degrees from the midline post delivery, right? And what are the components you have in active management of third stage of labor? Yes, I have plenty of mnemonics and I always teach with those mnemonics of mine. So for AMTSL also I have a mnemonic. I don't know whether you people know it or not, but AMTSL, active management of third stage of labor, may placenta will get expelled within 5 minutes, whether it is a primary or multi, right? And what do we do in this AMTSL? The mnemonic for AMTSL which I have is called as IDBI. You all know IDBI bank, no? So that is IDBI which I have. So I is injection oxytocin. Matlab, why did I write oxytocin? Any drug which contracts the uterus is called as oxytocin. So not only oxytocin, any drug which can contract the uterus can be used here. So injection oxytocin, that is oxytocin 10 international units IM, or you can give methergin 0.2 milligrams IM or IV. Where all methergin is contraindicated, very important. Methergin should not be given for after delivery of first twin, preeclampsia, isoimmunization, and topic cardiac diseases, right? And third one, you can give misoprostol. When you're giving misoprostol for prophylactic dose, it is 600 micrograms per vaginal. 600 micrograms per sublingual or per vaginal, right? So that is the I. D is delayed cord clamping. So you have to clamp the cord only after the cord pulsation stop. So delayed cord clamping after 1 to 3 minutes. B is Brands-Andrew method. Brands-Andrew method. Last I is intermittent uterine tone assessment. Intermittent uterine tone assessment. Okay, so that is regarding the IDBI. That is regarding the IDBI for AMTSL. Okay, I do have many more pictures. So this is the external cephalic version. We do it in the breech presentation. Do you know what is this maneuver which you are seeing in this picture? Do you want to guess this maneuver? So we'll go through the breech maneuvers as a last through images. So if you observe, we are trying to remove the aftercoming head of breech. But here, although you are trying to deliver the aftercoming head of the breech, where is the occiput facing? Occiput is facing towards the sacrum. Occiput is facing towards the sacrum. So it is the OP head, OP of aftercoming head. When you have OP aftercoming head, you try to flex and pull the both limbs vertically up as making as an arc. This is called as modified Prague maneuver. Modified Prague maneuver. Modified Prague maneuver is used for OP position in the aftercoming head of breech. OP position of aftercoming head of breech. Okay, it's called modified Prague maneuver. Ulta to this is the Bern Marshall. This is in the aftercoming head, but occipito anterior position. When occipito anterior position, you are pulling up vertically as an arm. This is called as Bern Marshall. Ulta for Bern Marshall is modified Prague maneuver. Modified Prague maneuver. Next, this is also one of the very famous maneuver for delivering the aftercoming head of breech. So what is this maneuver called as? This maneuver is called as Mauriceau-Smellie-Veit Maneuver. Mauriceau-Smellie-Veit Maneuver. So here modified, that too modified. What are we doing? We are giving shoulder traction. Then, sorry, we are giving shoulder traction. We are giving suprapubic pressure. And we are giving the malar flexion. Malar flexion. So when we are doing malar flexion, shoulder traction and suprapubic pressure all together, we call it as modified Mauriceau-Smellie-Veit maneuver. The difference from this maneuver from the previous maneuvers is you don't keep the finger in the mouth. No finger in the mouth. No finger in the mouth. Okay. This one where arms are stuck inside, body has come but arms are stuck inside. Arms are stuck inside can be extended arm or nuchal displacement of arm. So you can remember there you rotate the baby 180 degrees on either side. So to relieve the arm and pull it out. So you can remember the mnemonic as love sets in extended arm. Love will set with extended arm, right? Love sets in extended arm. What is this maneuver? Am I again showing MSV or is there anything different about this maneuver from the MSV? Am I again showing MSV or is this different from the previous maneuver? Anybody wants to try on this maneuver? So this also, if you observe, has the suprapubic pressure. Suprapubic pressure is there, malar flexion is there. But what is not there is the shoulder traction. What is not there is the shoulder traction. So suprapubic pressure and malar flexion, only those two together is called as Wigger-Martin maneuver. Wigger-Martin maneuver. Good, it's different. So how it is different? It doesn't have the shoulder traction. Agar if you have shoulder traction, three things hai to three names. Mauriceau-Smellie-Veit. If you have only two things, that is suprapubic pressure and malar flexion, then it is Wigger-Martin. Okay? And this one, where you're putting the finger in the popliteal fossa and pulling the leg out, this is called as Pinard's maneuver. It's called as Pinard's maneuver. This also again use it for aftercoming head of, this is used for arrested lower limb. This is used for arrested lower limb. Finger in the popliteal fossa and pulling it out is called as Pinard's maneuver. Pinard's maneuver is used for arrested lower limb. So those are the different maneuvers. I'll just go through those. So this is Prague maneuver, modified Prague maneuver. This is Wigger-Martin for aftercoming head of breech. This is modified Mauriceau-Smellie-Veit maneuver. This is Lawsett's maneuver for extended arm. This is Pinard's maneuver for arrested lower limb. This is again Bern-Marshall, right? So that was about today's session where I tried to show you some of the images, USG images as well as maneuver images, right? So all the best, guys. Please sleep early so that you will reach the center early and nothing. Now at this point, don't let any negative thought enter in your brain. Just be calm, composed and tell yourself 100% I'll do very well. 100% I'll do very, very, very well. And the only thing is that when you go to your exam, I'll tell you a few points before I'll end the session in another 1 minute by telling you a few points. I'm also a girl who used to, like, stand with the book till they'll call, come inside, come inside, come inside. I know that is what happens, but no, don't do that. So at least go at least 5 minutes prior, especially 5 minutes prior. If you are going and sitting there, not an issue. Last 5 minutes, nothing we can read or we do or something like that. So go sit there for 5 minutes prior so that you get accustomed to that place. Then close your eyes to just tell yourself, "Ki today I'm going to get energized and filled myself with a extreme energy, so that energy I'll be able to focus on the exam and give my 100%." The only funda is that you have to give your 100% in the exam. No negative thoughts कि मैंने सब कुछ पढ़ा क्या, मेरे को सब याद आएगा क्या, ऐसे सोचना ही नहीं. You don't even think, don't entertain any of that thoughts. You will remember everything after going there. You have read superb and extraordinarily. Your preparation is awesome. When you go there, read the question slowly, answer 4 options. Manu, if you're not understanding, don't waste time on that question, go to the next. So keep a grace of 100 and 50-50. So that 100 also gone means we will get the 200. That should be your target. Okay. So be positive, guys. All the best. I wish you all the best. And hope you'll all come out with flying colors and do very well in the exam. So my last advice to you all is fly in the plane of ambition. Land in the airport of success. Luck is yours, wish is mine. May you all rock in your exam. Right? Thank you, guys. Yes, Shahid. Please explain abruptio placentae and placenta previa. Okay. Right, Shahid. So I'll tell you in a very simple way. Abruptio placentae. Abruptio placentae mein what is happening is placenta is getting separated early. Normally, placenta should get separated in third stage. But what is happening here? Placenta is getting separated early. Bichara uterus will think placenta got separated. Let me throw everything outside. So what will it do? It will go on contracting. As it is going on, as the placenta is getting separated, they will have bleeding. You will have bleeding for vaginum. As the uterus is contracting, you will have painful. So the bleeding which you're having is going to be painful. When the bleeding is when you're having continuous contraction, so it is causing pain and that is decreasing the blood flow to the fetus. As well, the placenta is getting separated. So obviously the baby, how is the entire nutrition baby is getting? Through the placenta. But when placenta is getting separate from maternal sinusoids, so obviously the blood flow to the fetus is compromised. So baby will have fetal distress. So you'll have decreased fetal movements. On examination, patient may be in shock. Uterus is hypertonous and tender. Uterus hypertonous and tender. Uterus hypertonous and tender. There can be fetal distress to death. Fetal distress to death. Okay. So, how can I confirm is clinically only I can confirm this. When I do PV and if I do ARM, artificial rupture of membranes, you will see blood stain liquor coming out. So on ARM, you will see blood stain liquor. That confirms my diagnosis. Oh, I'm really dealing, and that is how I'll come to know. So there is two benefits of ARM. One, you will see blood stain liquor. Two, you're also going to see that there is it is going to augment the labor. Now, treatment is there any point in waiting on the baby which is having abruption? Even if I wait, placenta will not wait in separating. So gradually baby will go into hypoxia. So best thing for abruption is immediate delivery. So we follow something called as Pritchard rule. Pritchard rule, that is immediate delivery and simultaneous resuscitation. I have to deliver her also and I have to resuscitate her also. So hematocrit should be maintained more than 30%. Urine output should be maintained more than 30 ml per hour. Okay. Now, mode of delivery will depend on the fetal status. If fetus is dead, mother can go into DIC, so check for the maternal status. If mother is having DIC, correct the DIC. Correct DIC and then do the vaginal delivery. So as the baby is anyway dead, you have to try for vaginal delivery only. If fetus is alive, okay, and there is fetal distress, please go directly cesarean section. So in abruption, only when there is fetal distress, you'll go for cesarean section. Otherwise, you'll not go for cesarean section. If fetus is alive and there is no fetal distress, try for vaginal delivery. You'll try for vaginal delivery. Okay. This is in short about abruption, child. So basically, you have to know that यहाँ पे placenta is getting separated, so uterus is going on contracting to push everything outside. Okay. Now coming to so it is a premature separation of the placenta. Coming to the placenta previa. Placenta previa is placenta lying in the lower uterine segment. Normally, placenta should be in upper uterine segment, but here placenta in lower uterine segment. You can wait and watch for this to migrate up. Basically, it doesn't migrate, but uterus goes on growing. So along with that, it can pull it up. So it is a placenta in the lower uterine segment, in or over the, on, near or over the internal os. Near or over the internal os. In contrast to abruption, the clinical picture in placenta previa is it is painless bleeding. Multiple times it can happen. Painless, causeless, bright red bleeding. यहाँ पे uterus is not contracting, so there is no fetal distress. But baby can be abnormal lie. So on examination, uterus relaxed. Their uterus was tender. Here uterus is relaxed. The main way how you will differentiate whether it is this answer or that answer is, if uterus is contracting and painful bleeding, abruption. If uterus is relaxed and painless bleeding, it is placenta previa. Okay. And you'll have malpresentations. And you have something called as Stahl-Worthy sign. On pushing the presenting part, there will be decrease in the fetal heart rate. On pushing the presenting part, there will be decrease in the fetal heart rate. Treatment is, if you have type 1 or if they come to you with some bleeding or anything before 37 weeks, before 37 weeks, you don't want to deliver her. So you wait and watch on her. You admit, give her steroids for lung maturity, give her tocolysis if any contractions, and monitor her. This before 37 weeks wait and watch is called as McAfee and Johnson's regimen. It's called as McAfee and Johnson's regimen. If she's more than 37 weeks, then deliver her. Type 1 or type 2A, normal vaginal delivery you can try. Type 2B, type 3 and type 4, cesarean section. Manu, if they don't mention anything, directly go for cesarean section. Okay. So I didn't give complete in total about this, but the important pearl-like points which are there for you to differentiate between both of them, I tried to put forward those points. So thank you guys. Once again, all the best. You are all going to rock. So let me hear a good news from all of you. Thank you guys. All the best. Right? Any further doubts before we end the session? Thank you. Good night. Sweet dreams. %, I'm praying for all of you. Don't worry, you'll all 100% going to rock. Okay, all my prayers with you, and probably I'll come inside your brain and try to answer also, help you to answer also, right?